Welcome to the Pupil Pod, where we use clinical cases to guide discussions on board review topics. I'm your host, Sila Bal, and my guest today is someone that I consider one of my mentors, Dr. Bill Trattler. Dr. Trattler is a refractive, cornea, and cataract surgeon at the Center for Excellence in Eye Care in Miami, Florida. And when we were reviewing this podcast episode, we wanted to mention that he is also an excellent skier and probably one of the best skiers that I know. Dr. Trattler, thank you for joining me tonight.
Oh my God, this is so nice to be with you. Thank you so much for having me. I feel very honored.
So let's jump into the case here. We have a 31-year-old woman who presents with right eye pain and decreased vision. Left eye is completely normal. Examination reveals a vision of 20/60 in the right eye and 20/20 in the left eye. Slit lamp examination shows conjunctival infection and a unifocal area of stromal haze without any epithelial defects. Now, Dr. Trattler, at this point, very early on, what additional questions would you ask this patient, and what, if any, are the additional examination findings that you would really want to hone in on for this patient?
Right. So I guess we're thinking that there's inflammation going on because you're saying that there's a cloudiness to the cornea, there's a haze of the cornea, stromal haze. And so we want to figure out like what could be causing an inflammation, because some people could have a scar from years ago, but it's going to have a different type of appearance. Here, it sounds like there's an inflammatory reaction going on. So we're trying to think of conditions or situations that would cause inflammation of the cornea. And obviously, we know the most common types of causes would be some type of viral infection, specifically either herpes zoster or herpes simplex are well-known risk factors for getting an inflammatory, like haze of the cornea. And so typically I'm going to ask the patient if they have any history of either of those two conditions. Maybe they had a history of cold sores, maybe they have a history of previous corneal infections, but trying to get a history is always very helpful. And then for signs, we're going to, of course, look for any type of inflammatory cells in the anterior chamber. And of course, we want to make sure the retina is healthy and everything else.
And I think I misspoke. I said conjunctival infection, so I gave away the punch here, but I'm talking about conjunctival injection, which doesn't necessarily mean that there is an infection. As you alluded to, there can be rheumatological causes, autoimmune causes to this, but really we're honing in now on the infectious component about this. So let's say that you're concerned about interstitial or stromal or disciform keratitis, all synonyms kind of for the same disease pathology. What else do you kind of think about when you see an interstitial keratitis?
Well, I guess the first thing I'm trying to understand is, first of all, how long has the patient had reduced vision for? Is this something that they've had for years and it's just got a little bit worse? They had a new inflammation, because maybe this patient's had, haze of the cornea and poor vision for many, many years. Or is this a new onset where they were seeing really well until 2 weeks ago, and all of a sudden they notice a significant drop in their vision? This is a more new onset of this inflammatory condition of the cornea. So I'd like to know the timing, because our concerns are of course the same in that we want to figure out the treatment, but our expectations of recovery might be a little bit different. And so I guess that's one thing I love knowing is the timing of this of the vision loss.
So this patient came in with about 1 week of decreased vision. So it's really an acute presentation at this point.
And that helps. It tells us that that this is something that's active. That we see the inflammation, the redness of the eye, and we know there's inflammation going on. But we're suspicious of a viral style type of infection that is contributing to this condition. So we're going to really try to come up with a treatment plan that will really address the underlying cause and also treat the inflammation.
Absolutely. And when I look at these interstitial keratitis patients, as you said, the number one thing you want to know is this acute or is this kind of a chronic process? And when you see these, it can be those viral etiologies like HSV and VZV, EBV, but it can also be really strange things for this interstitial keratitis like Lyme. Sarcoid does everything in the eye, as we know, atopic keratitis, and even vernal keratitis. So we don't fully rule those out, but with the acute process and the acute presentation, it kind of leads us into a specific direction, and that is HSV. So Dr. Trattler, how do you kind of think about the different forms of HSV keratitis, specifically based on the location that you see the pathology?
It's a great question, and HSV, is one of those great mimickers. It could look like so many different things, and I'm glad you mentioned all the different differential. But so often it ends up that it is an HSV as as the underlying cause. And so basically, what we're um, trying to assess again is, how did this patient get this infection? Is this something that's like they've had for a long time? It's a recurrence of something before, and so maybe they had a history of an epithelial infection 5 years ago, 10 years ago, 20 years ago that they remember. Oh yeah, I saw my eye doctor. They prescribed a topical antiviral or oral antivirals, and tells you that they've already had a previous type of assuming it's HSV infection, but it was more superficial. And then, now we know this is more a deeper inflammatory condition of the eye, and so we're now thinking like this is, a second or third type of insult to the cornea, and we're going to be thinking of different approach to treating this versus the initial presentation of if you had a first episode of an HSV keratitis.
Absolutely. That's such an important point that you're making. Usually in pediatric patients, we'll see like that classic vesicular rash. You'll see a blepharoconjunctivitis. Sometimes you'll see epithelial lesions. Very rarely in the primary infection do we see a stromal keratitis. Generally, when you see the stromal keratitis, you're kind of thinking that this is a reactivation. And with those primary infections, they're self limited, right? But we obviously treat them with antivirals because it speeds recovery and we kind of feel better treating those primary patients. But focusing on our stromal patients that have this reactivation, what are the two forms of stromal keratitis? So we have the anatomy of HSV infection, right? We have epithelial, stromal, endothelial, and then kind of the iridocyclitis. But what are the two types of stromal that we can categorize in our minds?
Well, I mean, maybe I put them together too much, but again, when it's affecting the stroma, I'm you're going to see it can be in different levels. It can be more anterior, but affecting you know, the the under, the interior part of the cornea, or it can be deeper at times too, and it could get close and almost get endotheliitis. Those are the cases where you might get raised intraocular pressure as well. And so um, I'm interested to hear how you categorize them. But basically, for me, I kind of categorize them together because I know the treatment's very similar. We're going to be using anti-inflammatory medications because we know there's an inflammatory condition, despite the fact that there's a viral underlying cause.
Exactly. And I think of it the same way. I just use the terminology of non-necrotizing for the endotheliitis version and then necrotizing for the more anterior that kind of looks like almost like a fungal ulcer sometimes. These patients can come in with necrotizing stromal keratitis. And I mean, I'm sure you see them down in Miami. It looks really bad. And sometimes it's difficult to discern. I know when I was a fellow, I think I treated a couple patients as fungal ulcers and they just weren't getting better and their cultures weren't growing fungus, but I was so convinced that it was fungus. And then we treat them for necrotizing stromal keratitis for HSV and they get better. And it was always so shocking how bad the cornea looked.
Oh my God, yeah, it looks almost like canals can come into the cornea. Like they look like these divots in the cornea, and they form like these almost canals or rivers through the cornea, where it's almost as like basically a melt. And they're very difficult because you're going to end up with such irregular corneal shape, and it's going to really impact their vision significantly. It's not just the haze, but it's the irregularity that these patients end up with. And I've known patients that have had that over the years, and I manage them and continue to manage them. And it's always disappointing, like sad that I don't have an easy fix other than scleral lenses for after we've gotten rid of the active infection and active inflammation. We're stuck with trying to have them use scleral lenses for vision.
Well, speaking of treatment, can you tell us or walk through kind of how you would treat this patient if you were worried more about a non necrotizing stromal keratitis, so the endotheliitis type patient?
Right. So let's say that, I have so many patients that present like this. It's very frustrating, but they come in and they have this, haze in the central part of the cornea where thankfully it's not involving the epithelium. It's not involving any type of melt. We're really going to hit them hard with topical steroids because they're trying to suppress the inflammation. And then we usually, and we'll talk about this, I'm sure, next, even though there's no great studies that show how that we need to have antivirals. I'm a big fan of using antivirals for not only treatment but also prevention of the um, next stromal keratitis because we know that when someone has a recurrence of HSV, which this is, their risk for a second recurrence is very high, in the next year. So we're going to treat them actively with a higher dose of antivirals. I'm a big fan of Valtrex, and then we'll keep them on a prophylactic dose for I usually like a couple years, even longer sometimes, because I don't want them to get the next episode that will take away even more of their vision.
There's so much controversy around this, and some people say you don't need to. If it's just stromal, you really just need the steroid component. Others will do the full treatment and then keep them on it for a year. Others, like yourself, will keep them on it for years. I think the important thing to note, and I think for the audience, is that the antivirals aren't shown to necessarily treat the stromal disease, which is, as Dr. Trattler mentioned, the mainstay of treatment is really the steroid, but the antivirals are there to prevent epithelial disease and prevent recurrence of disease. And so that's why people kind of differ and go back and forth about this. So, the big study on this is the herpetic eye disease study. And other than the fact that it showed that we want to treat stromal disease with steroids, it also kind of showed that oral steroids don't prevent anything. Dr. Trattler, have you ever used oral steroids for these patients? Do you ever think about oral steroids?
Absolutely not. And I mean, I think that this is a local infection, and we know topical steroids get such good levels in the cornea, so it's just more effective, I believe, to use topical steroids. And we're going to hit them hard with topical steroids. We also want to make sure make sure we're covering everything else, make sure they don't have eye pressure. I mean, we're going to watch everything, but we're really hitting them hard with topical steroids to try to suppress the inflammation, get that haze to fade away, and to be less visually significant.
Exactly. And, the other things that the herpetic eye disease study found, like we kind of have been talking about this entire time, is that we're using the antivirals to prevent the recurrence of stromal disease, but also that there's no confirmed triggers for HSV keratitis. And I think that's an interesting one, an interesting discussion that I have with patients because they always ask, like, what am I doing wrong? What have I done wrong? Is there anything that you tell those patients, any specific counseling you offer them?
Right. I mean, there's always the myth that it's stress is the risk factor. And I hate to it does always happen that my patients come back with recurrences where they have stressful things have gone on, like just crazy stressful things, all of a sudden they get this recurrence. Is it coincidence? It's just hard to know. Maybe they also think about the stressful situation. They're always stressed, and now you just have the recurrence. But and there's obviously no way we can handle or not have stress. We all have stressful things occur in all of our lives. So that's why prophylaxis is so important because I know again I've had patients that have had this for because I've been in practice for way too long that 10 years ago they had this infection they'd been quiet for 10 years and it comes back again and you wonder, because they stopped their antivirals, should we have just kept them on the entire time? And maybe, and
Yeah.
because this next time they have more vision loss, their vision was still good, and now it's permanently worse because they had, just a more damage to the cornea.
It's just one of those things that you really have to have a discussion with the patients because as a young ophthalmologist, I am really reluctant. Like I practice more conservative medicine. I don't want to take my patients off these meds because I'm worried about them. But I think as you gain more experience, you have a little more confidence in taking them off and not prophylacting as long. But for now, I'm like, just take it. It's harmless. Take it, please.
Right. No, I think I'm in the same boat. It's just that when they're doing well for a while, they don't come back, and then they kind of their prescription runs out, and they just don't refill it. Right? It's been 5 years, and they're doing their own thing. Life is good. Maybe they don't wear glasses, they don't go in for any more checkups because their vision's good, everything's good, and they just forget about it. And that's what's happened to some of my patients because, again, and then they come back years later.
Exactly. I mean, I imagine our patients with all the drops and medications they take, and I can't picture myself doing it. I can barely take a multivitamin once a day. So I really give them credit for sticking with their medication regimen. So let's talk about if this were a different patient. Okay. Let's imagine that instead of coming in with the stromal keratitis, they presented with an elevated IOP with patchy iris transillumination defects. What would you be thinking about at that point, and how would you manage that patient differently or not?
Right. So these are patients where, again, I always kind of think of, and I think you alluded to earlier, that the virus can impact different parts of the eye. And here you're seeing that it's affecting the iris and affecting the trabecular meshwork. And so we know this is a deeper infection, and and you can have all different findings, from HSV. But again, we're always watching for eye pressure being elevated. And here we know there's a trabeculitis and iridocyclitis. There's going to look for cells in the eye, and we're expecting that this patient will be a little bit more difficult to treat sometimes because it can even go deeper into the vitreous, and there's a risk for other even more serious infections of the retina.
Exactly. And I think what's interesting to note here is that the herpetic eye disease study didn't show if oral acyclovir or oral antivirals are helpful in these patients. They said that the number was kind of too low to know yes or no. So most of us will treat with steroids plus antivirals. Is that what you do as well, Dr. Trattler?
A
Always.
100%. Because again, we want to get them on the antiviral for oral antiviral for long term, and that's the best way to get them started on it, and then have them maintain it afterwards. Because again, we're trying to avoid recurrences.
Exactly. So there's one more location that we haven't talked about, and that's the one that is kind of the sexiest, right? When you see those nice dendritic cells, you really know, okay, I know what this is. I can see this even as a junior resident, even as a medical student, and that's HSV epithelial keratitis. However, I always tell the junior residents that even if we see dendrites, it doesn't always mean HSV, right? It doesn't always mean HSV. So, what are some of the things that you think about when you see dendrites so that you don't miss any of these other diagnoses?
Right. I mean, I think that some of the more important ones for me are acanthamoeba and fungal infections, because they can often present with a dendritic-like appearance, and they could be very suspicious and go, "Oh my God, looks like HSV," and that's why these acanthamoeba cases and fungal infections are often the diagnosis is delayed because people are going down the HSV path when it's really not, and so you have to always have your eyes out. I mean, there's some really classic dendritic appearances like, "Oh my God, this is like," it's for sure a dendrite, but there's a contact lens where, when they come in and they have a dendrite, you got to be suspicious about, acanthamoeba. You have a patient that's working on somewhere like in agriculture, somewhere working where they couldn't get exposures to fungus, you may better be thinking about fungal infections, and again, watch these patients and expect a certain improvement. And if they're going the wrong direction, then you have to be just again be quick to refer if you don't do this, refer for a culture.
Exactly. And it's so interesting because we were just talking about how I had that fungal patient that I thought was fungal, but that was actually HSV. And now we have the opposite direction, which is you have an HSV patient that could potentially be acanthamoeba or fungal. But I just want to share with the audience a mnemonic that I really like to think about dendritic lesions, and it's that we hate dendrites. So hates. H for HZO and HSV, so like VZV and HSV. A for adenovirus, which can sometimes, pretty severe adenovirus can sometimes cause dendritic like lesions, and acanthamoeba, which Dr. Trottler you mentioned. T for Tygasins, which can cause all of these lesions on the anterior corneal surface that can kind of mimic this. Tyrosinemia, which does get tested pretty frequently. I don't know, Dr. Trottler, have you seen tyrosinemia? No, I also haven't. Not that I have, that much experience, but in the 6, 7 years that I've been doing this, I have not seen any tyrosinemia dendrites, but we do get tested on it pretty heavily. So it's one to know. And then for E, we have EBV and EBMD, which can both cause dendritic like lesions. And then rounding it all out, we have scleral contact lenses, soft contact lenses, really anything on the ocular surface that can cause these dendritic like lesions. So I like to think of that HATES to make sure that I have the whole spectrum, but really most of these we don't see. And the ones that you mentioned are really the most important, right? The herpetic viruses, the Tygasins, the EBMD, and then acanthamoeba do not miss in fungal
Right.
infection.
Absolutely.
So if HSV epithelial keratitis is self limited, why do we treat it? And do you always treat with oral? Do you prefer topical? How do you kind of manage these patients?
While it is quote self-limited, it can take a long time to go away in some patients, and again, we're trying to get patients on the understanding that this is a viral infection. They're going to need to take an oral medication long term, because I do admit that a lot of my first time HSV patients, I'll put them on oral prophylaxis for long term. I just don't want them getting recurrence, because the second case could be not another superficial epithelial recurrence. It could be a stromal keratitis or something very serious. So if it was me who had it or my family member, I would keep them on oral antivirals for a long period of time. I know that not everyone does it that way. So I think that's why I started for right away to get them on board. Um, Cost wise, they're very inexpensive. And when we go to the topicals, the one that we're typically using, Zergan, is quite pricey at times. So I can't always get it for my patients. Their insurance often doesn't cover it. So I don't always have the luxury of prescribing it. And I'm not a big fan of Veroptic because it's too toxic to the cornea. So if I either get Zergan, I'll add it if I can. Whether Zergan plus orals makes a difference versus Zergan alone versus orals alone, we don't know the answer, but I sometimes will do both, and then patients stay long term on oral prophylaxis.
So how would you counsel this patient on their prognosis? So we're going back to our patient that just has the stromal keratitis. How would you kind of talk to them about your treatment plan and prognosis and the potential for complications? We've been talking about it a lot throughout this episode. We treat because we want to shorten the course, we want to prevent long term scarring. So, how would you kind of talk to your patients about this?
Right. Well, the first thing I bring up a little bit more now, just because of the whole discussion of neurotrophic keratitis, is that patients who have HSV infections lose corneal sensation, and they're at high risk for developing a neurotrophic keratitis that could have nothing to do with their HSV. It's just their cornea is more susceptible to breakdown. And so, if they scratch their eye, they may not feel it as much. And so I do talk to them that their cornea is at much higher risk for future complications. We have to be really on top of things. And so we're going to talk about prophylaxis because we don't want a recurrent HSV infection, but also they have to be very aware that if they get a red eye, if their eye becomes blurry, they got to come in because they could be getting signs of a neurotrophic keratitis.
Absolutely, so important. And just thinking along the lines of those complications, when do you take patients for surgery and kind of what is the outcome for surgery? Do you prophylact these patients? Let's say you take them for surgery for PKP because of scarring. How do you manage those patients versus patients that have a clear cornea and you're just taking them for cataract surgery?
Okay, so let's do cataract surgery first, and then I'll give you my philosophy on corneal transplants. But first, for cataract surgery, anytime we're going to do a procedure on a patient that has a history of HSV keratitis, we want to prophylax against a recurrence. And because we know that insults like doing surgery, inflammation, that could possibly like lead to a recurrent infection. And it's not fun to do surgery and have patients get a recurrence right afterwards. Right? It's just not fun for them to present a week after cataract surgery with a recurrent HSV keratitis and something bad. So why not hit them hard? And so we start usually about a week ahead of time with I use a full dose, the 3 times a day oral Valtrex, and then usually extend it for about 2 weeks afterwards, and keep them on it once a day for 6 months at least, um, because I just don't want to have a recurrent infection anywhere, HSV infection anywhere near the my beautiful surgery I just performed. And that would go the same with any other surgery you're doing. If you're doing a retinal surgery, if you're doing pterygium surgery, if you're doing anything, you just don't want to have a recurrence.
Absolutely. And that's kind of what I follow to keep prophylact them before and after the surgery. But tell us, please. I'm excited to hear your your theories on corneal transplants.
I will, but I do want to add one more thing. So one other thing that people will come up, which is actually a controversial topic, is doing PRK or LASIK in patients with a history of HSV. And so I will say that I have done that in the past on patients that were very motivated because they needed to do it. And like one was just just because I still see her. It's been 15 years since I did her PRK, but she was a low myope. But was doing activities where she just couldn't wear glasses or contact lenses. She wasn't tolerating the contact lenses well, and she understood the risks, and she just felt that this is what she wanted to do. And so we talked about it a lot, multiple visits, and then we just did the same prophylaxis a week ahead of time, 3 times a day. Oral medication, Valtrex, and then for I think about 3 weeks afterwards for her, and then we kept it on once a day for about a year for her because again I didn't want to have a recurrence anywhere near the time of her surgery. And I know when I've done surveys, about 50% of doctors who do refractive surgery raise their hands and say yes, they do at times a patient with a history of HSV, they'll do PRK or LASIK. Another 50% will say they'll never do it. And so it's so controversial at times. And if you're going to do it, just be very proactive with oral prophylaxis.
That's such a good point and really important to understand that a lot of these things are based on experience and comfort level and just that discussion like we were talking about with our patients so that they understand the risks and then they can kind of feel empowered to make those decisions on their own rather than us telling them they need to do this or that. That being said, I have not done any refractive surgery on a patient with a risk or a history of HSV, but I think, as I get further into my practice, it would be definitely something that I would consider, especially in a highly motivated patient that I know was going to take their medications and kind of follow up as I request. So
Exactly. And also years out from from the age. It's not something they had a month ago. They had it years. And oh yeah, by the way, when I was much younger, I had this happen. Again, so it's remote. Remote. It's not recent. I am very lucky in South Florida. We had the best scleral lens fitters that you can ever imagine. We have, again, just experts that are lecturing all over the country on scleral lenses, and those that don't are just really experienced. We, just have a great group. And so truly for our patients that have corneal scarring and irregularity, it turns out that the scar is not the real issue. It's really the irregular shape. And if you fit them with a scar lens, most of these patients get reasonably good vision. So it's extremely rare to have to do a corneal transplant in a patient with herpes keratitis or stromal keratitis, because usually they can be fit with a scar lens. Because if they do undergo a corneal transplant, unfortunately, the success rate is just fair. I mean, um, I know I know you know some of the statistics, and I'm sure you'll quote them in just a minute. But the point for me is that when a patient undergoes a corneal transplant, you know, it can go south. They can get recurrence that could lead to severe corneal scarring. They can get, lots of complications. And again, a percent will go really well, but guess what? They're still going to wear a scleral lens in many cases. You're not necessarily uh, giving them a perfect corneal shape. They're going to have some irregular astigmatism, lots of astigmatism. And so our philosophy is to try to avoid corneal transplants, get them fit into scleral lenses. And with our scleral lens experts, the vast majority can be very successful. So corneal transplants at our practice of 15 doctors with 4 cornea specialists is exceptionally low. And I mean, I think we do less than 1 transplant a year for HSV, because again, there's just so much risk around it, and the success rate is nowhere near as good as transplants for other indications.
I think that's a really important point to make, right? The patients that are requiring a keratoplasty are the patients that have had presumably severe disease. And those are the patients that are going to do worse if we do surgery on them. And so if we can do everything that we can in our toolbox to minimize the need for surgery, we're going to do that. That being said, the studies or the data do show that if you do an optical PK, nearly 80% are successful if they've been quiet for at least 6 months. Now, if they're not quiet, if you're not prophylacting them, if they have severe disease, I think those numbers are different. But again, this is a PK. So this is lifelong management of a corneal transplant. It's a big surgery. It's not a little thing. It's not a scleral contact lens. So if we can put them in scleral lenses, that in my mind is the preferred treatment. It's just a matter of that small percentage of patients where we have no other options that we kind of have to put them in scleral
Right.
lenses.
Of course. Oh, I was just going to add that remember that when you're doing this transplant, these patients are neurotrophic, so that also reduces the success rate of transplants because their corneal nerves are not normal, and they're very susceptible to injuries and scratches and other things that can lead to real serious complications. And so again, while 80% might sound good, maybe 80% sounds good, it's a B, but that means 20% of your patients had a problem. And when you're in practice and you have 20% of your patients have a problem, that's a very high number when we're used to cataract surgery with a 99% success rate and other surgeries that have 99% success rate. So again, we have lots of other tools that we can use. And so that's why we try to avoid transplants when we can, if possible.
Absolutely. And just talking about the neurotrophic patients, when you have these neurotrophic patients, if they look like they're thinning or about to perforate, do you ever perform tarsophies for these patients? How do you manage those patients, like the severe neurotrophic disease from HSV?
Those are our toughest patients because, again, you trying to avoid transplants or trying to do other things. And so tarsophies are one thing. I often will do like again punctal occlusion to raise the tear volume. We use lots of different gentile gel, things like that. But then we'll use a tape tarsophy in many cases where we put the scotch tape across the eyelid, try to keep their eye mostly closed for most of the day. And also a scleral lens can work really well because it can keeps the eye moist the entire time. It's bathing the cornea in fluid. So there's a lot of different things we can try to do. I work with my oculoplastic specialists and my team to try to save the eye and provide the patient as much vision as possible.
Absolutely. I remember when I learned about a tape tarsophy as a resident, it felt like a hack, like a life hack for patients that you could just offer them a tape tarso and it would really help them so much. So, for our listeners, tape tarsophy is an excellent option, especially in the acute phase, just to keep this eye closed as much as possible when the patient looks like they're at risk for a perforation or that they have severe ocular surface disease. So, big topic, very important topic, very common topic that we face in cornea as cornea specialists, but also in comprehensive ophthalmology. Dr. Trattler, that was amazing. Anything else that you want to add about HSV or about this topic in general?
No, just thank you. This is just such a great topic. We don't talk about it enough in these type of podcasts, and but it's such an important thing because we see it all the time. And I just, again, the most important thing for is probably the epithelial keratitis, dendrites, just to keep a watch out for the mimickers that, could be, again, especially acanthamoeba and fungal keratitis. Those are the tough ones that, just to watch out for.
Absolutely. So, Dr. Trattler, before we end the episode, I do ask all of my guests if you could have dinner with one person from any time or place in the history of humanity, who would it be?
Well, it's a great question, and obviously, I wish I had more time to think through that because there's so many incredible people that we've had, and it could definitely be, deep and all different ways. But I'm just gonna be fun because since I was in high school, my favorite group was U2. I've always been a big U2 fan, so it's one of the I don't go to many concerts, but anytime U2 is playing anywhere in the United States, I try to go at least once one show per time that they play. So and I did get a chance to go to Vegas and see them twice, which is a lot of fun. So I just love that. It'd be great to spend have dinner with Bono and just talk to him because again his music's been very impactful and so fun. And again, not I don't even know what I learned from our discussion. Although again I know it'd be fun to spend time with him. And again, I'm sure again other people have more impactful names and but I just thought, for me, that'd be really fun to spend some time with him. So I hope that's an okay answer.
That is such a fun answer and a very you answer. I would expect nothing less. I wish I had some pull in the celebrity scene that I could get Bono to have lunch or dinner with you, but maybe one day we'll link him to this podcast and we'll be able to get that arranged for you. But Dr. Tratley, thank you so, so much for joining us today.
Oh my, thank you so much for having me. This has been great. Thank you so much.
And thank you to those tuning in. See you next time on the Pupil Pod.